Assalamu alaikum. Good afternoon. The today lecture is the Ptosis, and I think we've just discussed it in the basic science course. So just to have some modification, it will be more of clinical aspect rather than basic science and the anatomy part. As you know, what we mean by ptosis, you might read it in some books, blepharoptosis, to differentiate it from ptosis of other organs, because ptosis in general is drooping of an organ whatsoever, the eyelid, the visceral organ, or commonly talked about the pelvic muscle ptosis in females. So blepharoptosis is coming from a Latin word which is divided into two parts. Blepharo means eyelid, and ptosis means falling down. So it is actually a drooping of the eyelid. It can be upper eyelid, lower eyelid, or both. But by default, when we talk about ptosis, we are talking about the upper eyelid. It might be unilateral, bilateral, mild, severe, simple, or associated with other syndromes. So ptosis is one of the most common oculoplastic disorder that you may see in your practice, and the diagnosis is somehow easy. However, the surgical outcome is always challenging because of two reasons. Number one, patients is expecting to have almost normal eyelid after intervention. And this is particularly important if you are talking about unilateral case, because patient is usually comparing the treated ptotic eyelid to the normal. It is not a static position that you would love to have the result on, but it is a dynamic. So patient might have excellent results in a straightforward or primary gaze, but the difference now became evident when the patient is moving the eyelid, looking down or closing the eyelids. This is why it is a challenging issue. The majority of cases are either congenital or involutional. The other types of ptosis is not that common. So by far the most common types of ptosis you see in our practice is the congenital here, and in Western countries are the involutional type. The other types can be grouped under the unusual types of ptosis. However, to start with, you have to identify and exclude pseudoptosis. This is very, very important. The patient complaint is usually unilateral or bilateral drooping of the eyelid. The parents might complain of abnormal looking eyes or unequal eye opening. However, you have to address the actual patient complaint. It is not uncommon in your clinic that the patient is complaining of drooping of eyelid. But when you clarify, and I do recommend to give him a mirror and the Q-tip and let him point at where is the actual problem, because usually they tend to complain of drooping of the skin itself, not the actual eyelid. And in females, this is of particular importance because they do compare the pretarsal shore. This is the area of the eyeshadow. So due to unequal areas of pretarsal shore, they tend to complain of drooping of the eyelid. However, the actual situation is a pseudoptosis. This is very important before handling the patient to address what is really his actual complaint. It is very important to ask about the onset duration and variability. If you missed the variability in terms of myasthenia gravis from the history, take it for granted. You're going to miss myasthenia gravis. So myasthenia gravis, it's only detected by careful history taking from the patient. Also, if the patient has unilateral ptosis, always consider hearings low. And we'll see later how to assess hearings low. And because of this particular point, you might read in some books that congenital ptosis is by far unilateral, the most common. And in other books, it is bilateral. To overcome this conflict, patient who has unilateral ptosis, they tend to have bilateral, but because of the hearings low, they have overestimated lid retraction on the other side. But when you correct this one or assess hearings low, you will find there is a bilateral element in congenital ptosis. On the last 5 years, it's coming more and more common to see ptosis secondary to Botox injection. And as you know, acute onset ptosis or recently developed ptosis is usually hides something dangerous. So in the ER, if you see a patient came to you with ptosis reported over the last 10 days or 2 weeks of acute or subacute onset, you have to think about Botox injection, male or female. Usually, Botox is given on the eyelid, but sometimes on the eyebrow, and patient rubs her area of injections even during sleep, and they tend to have ptosis. So it is very important to clarify. Whenever you ask about cosmetic issue, when you ask female, don't ask the female in front of her attendants, especially if her husband. Usually they deny. So you have to be smart in delineating the issue of cosmetic issue whenever you ask the patient about that. Just brief notes about the superficial eyelid anatomy. This is the upper lid. No, this is not the crease. Always remember, this is not a crease. This is the skin fold. If you want to assess the lid crease height, you have to ask the patient to look down, okay? Because this is actually the fold of skin covering the eyelid crease. And if this one is reluctant or the patient has dermatochalasis, you will assume that the lid crease is very low. However, the lid crease position is normal. So when you assess the lid crease, you have to ask the patient to look down to see the line of attachment between the levator and the skin. So we call this one is a pretarsal show, and this one is the skin fold. The upper lid crease is well formed because the upper lid retractor is very strong. This is unlike the lower lid crease, which is almost absent on the lateral 1/3. The lower lid retractor, despite having similarity in terms of the histopathological features, but they are weaker than the upper lid retractors. Here is the malar crease. The malar crease identifies the end of the thin skin of the eyelid and thick skin over the cheek. And mostly, if you have any edema here, this is our boundary here at this area. The palpebral fissure height, it is 9 to 10 millimeters. And the corneal light reflection at the center of the pupil here, the area between the upper eyelid and central area here is marginal reflex distance 1, MRD1. And this one is MRD2. It is very important when you document your measurement to document the palpebral fissure height and divide it into MRD1 and 2. The sum is the palpebral fissure height. If the patient has, for example, 10 millimeter palpebral fissure height with MRD1 3, MRD2 7, and on the other side it is 10 millimeters with MRD1 5, MRD2, what does it mean? That the patient, despite having same palpebral fissure height, but he has ptosis on the left side and the lower lid retraction. Okay, so it is very important to document MRD1, MRD2. Normally in pediatric age group, the upper eyelid rests at the upper limbus. This is normal in pediatric. With time, it tends to go downward by 1 to 2 millimeters. Palpebral fissure height, it is important to measure it here. And in some cases, when you see the contour of the eyelid is not normal, you have to measure it at the limbal area temporarily and nasally. Because some patients, for example, if they have lacrimal gland tumor, they tend to have S-shaped deformity of the eyelid. So tend to have lateral drooping of the eyelid. In case of thyroid, they tend to have lateral flare. So the eyelid on the lateral aspect is elevated up or retracted up. So it is very important to identify palpebral fissure height, MRD1, MRD2, the lid crease height when you ask the patient to look down, and the key factor in ptosis surgery is the levator function. And levator function, this is the most important vital eyelid sign that you have to document preoperatively as well as postoperatively. As I told you, the most important issue before handling any patient with ptosis is to exclude pseudoptosis. We have different causes of pseudoptosis, ranging from lack of support due to artificial eye in this side, contralateral lid retraction, as you can see here. If the patient has hypotropia because the eyelid tends to follow the globe, if the patient has brow ptosis or dermatochalasis. So it is very important to exclude these causes of pseudoptosis. Also, mechanical ptosis can be a cause due to chalazion, due to capillary hemangioma, orbital cellulitis whatsoever. It is very important also to exclude post-facial blepharospasm or what we call it apraxia or abnormal eyelid opening, because this might give you false impression of ptosis. However, the issue here is not related to the levator muscle. It is related to overacting orbicularis muscle. Now we'll go for history taking, examination, and evaluation of patient with ptosis. You will have long list of causes of ptosis. By far the most common is congenital, might be simple, associated with other anomalies. Acquired can be neurogenic, traumatic, myogenic, aponeurotic, mechanical. You will find this in any ophthalmic book. But what you have to clarify that if you missed the etiology from the history taking, definitely you will not be able to diagnose the patient, because the etiology here in ptosis in particular is based on the history taking. And of course, if you missed the etiology, definitely you will be having failed surgery. So we have some tips that you should not forget whenever you are taking history from the patient. The first, is it congenital or acquired? Some patients, they don't recall when did it start. So it might be a wise decision to ask for old photos. If they dated the ptotic eyelid since 10 years, so have a look at a photo 15 years, because usually they tend to have congenital element with some acquired issue. Always remember that if you have acute or subacute onset, it hides something dangerous. Having said that, you have to clarify about Botox injection or fillers. But whenever the patient is reporting recently developed ptosis of acute or subacute, you have to think about something that might kill the patient. So you have to clarify from the history, look at the pupil, see third nerve, see other Horner syndrome that might have carotid problem, etc. So dangerous ptosis, although it is rare, but still it can occur. So always think about these issues and think the worst first. So we'll start with some of the worst scenario that you might have in your ptosis cases. So in general, nobody loves you when you are down and out. So when you see such a patient, always think about third nerve with the whole dilemma of the third nerve ranging from simple issue medical up to surgical issue with posterior communicating artery that might rupture and kill the patient. And this is patient with third nerve palsy, and you can see here complete ptosis. The eye is going down and out. What is good here that the pupil is constricted. Diurnal variation, myasthenia gravis. As I told you, if you did not think about it during history taking, take it for granted. You're gonna miss myasthenia gravis. And sometimes you ask the patient direct question if he is bad historian, that the eyelid is ptotic more on wake-up morning or not. Don't give him direct question that it gets worse at the end of the day. But if you tell them that it's getting worse when you wake up morning, mostly they are replying yes if they pointed at diurnal variation. But the myasthenia, it has to be clear that the eyelid is in a good position when they wake up morning, and it worsens with the time. The general feature of myasthenia gravis that you have to clarify, that the patient might have weak jaw muscles, which make it difficult and sometimes impossible to chew, and myasthenia gravis symptoms can be eye muscle weakness, which makes focusing difficult. The weak facial muscles can cause the face to appear sad, and you can see here that the patient might have proximal muscle weakness. But it is not essential to have the systemic manifestation of myasthenia gravis before the lid manifestation. So you might have isolated myasthenia gravis involving the eyelid. What you can do to identify the myasthenia gravis, once the issue raised, you have to send the patient for neuro-ophthalmology consultation. You can do in your clinic the ice back test, just put cold ice over the ptotic eyelids for a couple of minutes, then evaluate the eyelid, which is getting improving. The ocular myasthenia is characterized by insidious, bilateral, but usually asymmetrical with diurnal variation. So usually the patient had bilateral cases, but asymmetrical. It gets worse with fatigue and in upgaze. The ptotic lid may show something we call a twitch and hop signs. When the patient is looking from down to up, you'll find the eyelid is going like a hop superiorly. They tend to have diplopia also, which is intermittent. Also think about ocular myopathies, which might be isolated or associated with oculopharyngeal dystrophy or Kearns-Sayre syndrome. The feature here, what is most characteristic here is the globe is getting more and more fixed up to frozen globe. What is interesting in this case that they tend not to have diplopia because it is symmetrical progressive. So despite having ptosis, limitation of extraocular motility, they don't have diplopia. It is very important also to ask whether it is traumatic or not, including surgery. Even putting the eye speculum in case of refractive surgery might enhance involutional element and patient will have a panoramic type of ptosis. Of course, manipulating extraocular muscle and non-surgical. Again, don't miss Botox injection or non-surgical cosmetic issues. If the patient has previous ptosis surgery or eyelid repair, and this is very crucial when you decide to operate a patient. Usually, if you resect in congenital ptosis, 10 millimeters as if you did nothing. So we are starting 14 millimeters and more. If the patient had previous surgery, each 1 to 2 millimeters you are resecting, it is equal to correction or to lag of thymus and lid lag. So it is very important before touching the patient to clarify if he had surgical intervention before or not. It will be evident if you are operating the patient under local anesthesia with any resection or advancement, but under general anesthesia you might have marked lid retraction postoperatively. The course, is it improving, worsening, or stationary? Simple congenital ptosis is stable. It does not improve nor getting worse with time. So this is very important. Also, family history is important in some cases like blepharoptosis syndrome. The history does not stop at this stage because we think that the systemic issue might not be important in case of ptosis. However, the story is completely different. So the medical and anesthesia history is very, very important. Not only because of the systemic association like anhidrosis or patient using anticoagulant which might have some bleeding, but congenital ptosis, they tend to have higher incidence of congenital heart disease. So it is very important to clarify these issues. Also, malignant hyperthermia, despite being rare, it might be a concern before operating the patient. We'll move to examination. We have some pearls whenever you are dealing with patient with ptosis. And the adult onset ptosis or the aponeurotic ptosis, the evaluation is somehow straightforward. But in case of congenital, you might have some challenges. So always remember that the patient is never too young to be examined. So whatever the age of the patient, still you can get valuable information from only an inspection. Whenever you are dealing with a child, always examine him by an inspection from a distance and get satisfactory information before approaching or touching the patient. Once you start to touch the patient or approach the patient, he will start to cry, and as you know, you will start to cry and you'll never have any valuable information. So get whatever you need from only inspecting the patient. The best way, because the decision here, should I operate him now, it is ambulogenic, or should I wait till the age of preschool age, the age of 5? It depends mainly on how much does it cover the pupil. How can you assess this one? If you are talking about looking at the patient with pen light or whatsoever, it is valuable if you are dealing with color iridis patient. You will be able to detect the pupil because of the contrast between the color of the iris and the pupillary area. But in our community, because of the dark color of the pupil, it is very hard to see how much the ptotic eyelid covered the pupil. So the best way to do it, hold the ophthalmoscope, be away from the child, sit on the same level of the child, and examine the red reflex. It gives you very clear idea about the partial or complete coverage of the pupil by the ptotic eyelid. And always remember, you are doing this without touching the patient. So the key factor to operate the patient can be obtained by only inspecting the patient away without touching the child. Then we'll go for the levator function. If you decide to operate the patient, should I go for levator resection? Should I go for frontalis sling? The levator function is very crucial in this issue. When you see a child and the lid crease, what I always hear from the resident that congenital ptosis, they have absent lid crease. This is not a scenario. The lid crease is directly related to the levator function. If the levator function is poor, you will not find the lid crease. But if the levator function is good, fair, or excellent, the lid crease will be evident. The better the levator function, the more obvious the lid crease. So the lid crease here can tell you about the approximate levator function. It is not actual figurement, but at least you can differentiate poor levator function from fair levator function or good levator function. So why you have to start with inspection? Because you should not miss the generalized issue, especially if you are comparing both eyelids. So look at the forest, not the trees. So whenever you are examining the patient, don't look particular at the eyelid and this eye. You should have general view of the face. It is not uncommon to have facial asymmetry or facial dysmorphism, which gives you false impression of ptosis. So you can detect pseudoptosis from these issues. When you go for examination, first, the degree of ptosis. Does it cover the pupil or not while the patient is looking straight ahead? And as I told you, you have to use the ophthalmoscope. The levator function. When you assess the levator function, you have to fix the eyebrow. And it is also important to trick when you look at the patient. If he is interested to use the eyebrow, the child, so especially if he has severe ptosis, this means that frontalis sling is likely to work nicely on his case. If he is not interested to use the eyebrow, mostly this eye is amblyopic and patient doesn't care about it. And post-operatively, you might not be very keen to use the eyebrow if you use frontalis sling. Also, if the patient is adopting any abnormal head posture, especially in bilateral cases, because they tend not to have amblyopia, but they will have some cervical deformity starting from the age of 1 year when he's interested to sit and to look at the far distance. This is how to use the ophthalmoscope, and always remember to sit in the same position of the patient. If you patient on the lap of the mother or the father and you are above, the child is looking like this, okay? So it tends to give you underestimation, and vice versa. If they are higher and they are looking from down, so the child is doing like this, so you will see the pupil, and in actual situation it is covered most of the time. So the palpebral fissure height, as you can see here, the best way to handle the ruler, because I've seen in the clinic that the residents sometimes they are holding the ruler with one hand and fixing the eyebrow with the other hand, so they haven't the ability to hold the eye, the muscle light, etc. So it is better just to hold the ruler with your hand like this. Okay, this finger, use it to fix his eyebrow. Okay, so with one hand you can take the measurement and fixing the eyebrow, and with the other hand you can hold the muscle light, etc. Always remember to fix the eye. If ptosis is 2 millimeters, we consider 1 to 2 mild, 3 millimeters moderate, 4 or more, it is a severe ptosis. The levator function, you might see different numbers in different textbooks, but mostly they agreed on the normal or excellent levator function equal or more than 13, good from 8 to 12, fair levator function 5 to 7, 4 or less is a poor levator function. Always remember that the infant and young child difficult to obtain reliable measurement of levator function. If you just try to evert the eyelid, we call it elf sign, just try to evert the eyelid of the infant or child and just let him go. If the eyelid is coming back spontaneously, mostly the levator function is not poor. But if the levator eyelid kept inverted and you have to re-invert it with your finger, the levator function is poor. The lid crease height, it is variable, male or female. It's usually higher in female. And as I told you, it is an indication of, indirect indication of the levator function. And the lid crease has to be reformed in any ptosis surgery. You might have excellent levator resection results or ptosis surgery, but the patients are completely unsatisfied and cite the eyelid because of the abnormality of the lid crease. So always remember to repair the eyelid crease. The eyelid crease in frontalis sling, you cannot attach it to the levator as if you did nothing. But you have to attach it to the upper border of the tarsus, and it has to be comparable on both sides. Otherwise, you can attach it to the levator fringe itself or the levator muscle after doing levator resection. So after you finish with the eyelid vital signs, for heaven's sake, do not forget the following. Number one, jaw winking. If you are not asking about this one, not examining this one, you're going to do another surgery which is not indicated. You're going to go for levator resection, and post-operatively the patient will have good primary position, very unsightly position of the eyelid and the lid retraction while he's chewing. So this is very important to ask. This is the myasthenia gravis, 100% you're going to miss it if you are not asking about it. But this one, if you will be lucky if the parents pointed at this issue if you did not ask or you missed it. But always think about the jaw winking syndrome whenever you are evaluating ptosis. Second, extraocular motility examination, which is very, very important. It is not uncommon because the levator and the superior rectus have the same embryological origin. Actually, the levator is coming from the superior rectus. So if you have congenital anomaly of the levator, what is against to have the same with the superior rectus? This is the origin. So always think about examining the superior rectus in case of congenital ptosis. And of course, if you have ptosis like the third nerve palsy or recently developed ptosis, always remember ptosis here is protective. If you correct the ptosis before correcting the position of the eyelid, the patient will never forgive this for you because he will be having diplopia. And diplopia is really, really bothering the patient if you compare it to a cosmetic issue like this. So always remember to elevate the ptotic eyelid and ask the patient if he sees double or not. In case he has to correct his diplopia first by strabismus surgery, and then you can go for lid surgery. Bell's phenomena. Bell's phenomena is very, very important because if the patients, usually after levator resection or frontalis sling, this is not a complication. This is a side effect to have lag of thymus and lid lag. The lag of thymus here, if it is minimal with abnormal Bell's phenomena, patients tend to have exposure keratopathy and keratitis. So it is very important to assess Bell's phenomena. As you can see here, when you ask the patient to close the eye, and while you are opening the eyelid, this is intact Bell's phenomena, this is defective Bell's phenomena. So during sleep, even if he has 2 or 3 millimeters lag of thymus, they tend to have corneal complication. And if you have such a case, always go for undercorrection. And you have to discuss with the patient about this issue. If you have mild ptosis, it does not make any sense to think about Horner syndrome if the patient has severe ptosis. But if he has mild ptosis, always look at the pupil. Because if the patient has Horner syndrome, especially if they are bionic, you have to send the patient directly to imaging. So they might have something that can kill the patient. So always think about Horner syndrome in mild ptosis. The hearing loss. Hearing loss is one of the important issues to avoid challenges after ptosis surgery. As you can see here, when this patient has ptotic left eyelid, okay, this position seems to be normal, isn't it? See what will happen if you don't perform hearing loss testing here. You're going to correct this position to that one. But what will happen after surgery? See, when you are elevating, see what is happening here on the other side? Okay. Is it evident? This is normal position here. After you correct this one, post-operatively the patient will be having ptosis on the other side. And he will show you, my doctor operated in this eye, and now I developed ptosis in the other eye. So you have to assess this one before surgery and decide with discussion of the patient to do simultaneous surgery bilateral. We'll go for the left side and we'll correct it as under correction, or we'll go to this actual position here that you see with ptosis, and post-operatively you might need another surgery on the left eye and the right eye, the other eye. So it is a matter of discussion between you and patient. It is not uncommon, to be fair, that the patient tend to have ptosis of this side post-operatively but transient, and then with time it comes back. So it is really challenging if you have a patient with hearing loss. Always remember to assess visual acuity and possible amblyopia, and you have to treat it, even post-operatively. So don't miss the patient, and you have to keep following the patient in terms of amblyopia or glass prescription. So ocular examination is also mandatory. So don't stop at this stage. You have to look at the eye to exclude pseudoptosis, to detect the etiology if the patient has vernal keratoconjunctivitis with continuous rubbing and aponeurotic element. The corneal sensation is very important because it will aggravate the condition if the patient has dry eye, or if you are thinking of myelorrhectomy or transconjunctival ptosis surgery and patient had bleb. So don't jump to posterior approach. In this case, anterior approach might be of tremendous value. We'll take the most common types of ptosis now, the simple congenital ptosis. The simple congenital ptosis has very strict criteria. It is dated back to birth, range from mild to severe, stable degree of ptosis, static lid lag with higher level than normal in down gaze. The lid lag, we have the static and dynamic. The static one, when you ask the patient to look down, you will find the eyelid is higher in position than the other one. You expect that this patient has ptosis, so when he looks down, it will be lower than the normal eye. But because of the muscle itself is dystrophic or whatever the etiology, in congenital ptosis, myopathic dystrophic, so the eyelid will be higher. This is unlike the thyroid. Thyroid is a dynamic type of lid lag. When the patient is looking down, the eyelid is lagging behind the eye at the duration or at the time of looking down. Patient, if it is a simple type, they tend to have full extraocular motility with good Bell's phenomenon. You can see here you might have different types, different degree, mild, moderate, severe, and you can see here the lid lag. So this is the ptotic eyelid here. So you would expect when the patient is looking down, this eye will be lower. But here you can see this eye is slightly higher. This is a mild degree of lid lag. Treatment of simple congenital ptosis is essentially surgical. But the question now, when should we operate the patient? If you can delay the surgery, the outcome will be better. Local anesthesia better than general anesthesia. If the levator muscle is well developed, or the age of the patient is more than 5, you will be able to handle the levator muscle in a better way. And an interesting article came in the NEG a few years ago that exposing the patient to general anesthesia 2 or more before the age of 5 might have impact on their behavioral and intellectual issues. So knowing that the congenital ptosis, they might have another surgery because you might have under overcorrection, any revision, you might have it. So put in your mind that you might expose the patient to 2 surgeries under general anesthesia. So if you delay it, and also you give time for the visual maturation. But if the patient has unilateral severe ptosis covering the pupillary area, partial or complete, so now we are talking about amblyogenic ptosis. So you have to treat him at early age, at the age of 1 year, or even earlier than this, at the age of 6 months. If the patient tends to have bilateral severe ptosis, they will not have amblyopia. They will adopt this head posture. So usually we treat them at the age that the child starts to sit and to be interested. While he is sleeping, is not a big deal. He will do like this and he will manage. But at the age of 1 year, you have to operate. You will do a minimal procedure here, the frontalis sling. And if you do frontalis sling in this age, we use synthetic material. The best is the Dyna rod, which has some elasticity. But you have to tell the parents that we're going to do this surgery now. Mostly your child will be in need for another surgery at the age of 5. At this age, because it tends to cut through and to have some undercorrection, you can take now fascia lata from the own patients, or if you can evaluate the levator function in a better way, you might go for levator resection, but you have to remove the synthetic material. This is an example of unilateral severe and bilateral severe ptosis. And you can see here the child is adopting this head posture. So in brief, the Levator resection, the anterior approach is just skin incision. And you can see the orbicularis muscle here. The incision only skin, then tend the orbicularis up to avoid damage of the levator. Then you put the levator septum under stretch, you cut it, and you can see the friendly fat, the pre-aponeurotic fat. Any structure behind the fat here is the levator. And you can see with pressure here, the fat is protruding. And after you evaluate the septum and take the fat with the decimal retractors, you can see the levator muscle here. Then you detach the levator from the tarsus, the vasculature here, indicating the mular muscle. So the muscle here under is the mular, this is the levator. You can see here. And then some surgeons, they are taking only the levator. Personally, I take the levator-mular complex together because it is not uncommon to find very rarefied aponeurosis to ensure that you are dissecting all the areas here. Then you hold the levator, you might cut the horns, measure the amount of resection. It depends upon the table. Usually in mild, we resect 16, 14 to 16, and moderate 16 to 18, and severe more than 18. But it is very important to look at the levator function preoperatively and adjust the eyelid intraoperatively according to the levator function. If you have levator function 8 millimeters preoperatively, put the eyelid exactly on the position that you need to see postoperatively. So if you resect 18 millimeters and you find the eyelid is lower, take another 2 millimeters and so forth. But if the levator function is less than 8 millimeters, they tend to have drooping postoperatively. So always put the eyelid in a higher position if the levator function is less than 8. If the levator function is more than 8, put the eyelid position in slightly lower than what you need to see, because postoperatively they tend to go up 1 to 2 millimeters. In the postoperative day, if you see lid retraction 1 to 2 millimeters, it tends to improve with time. Massage can do the job. But if the lid retraction more than 2 millimeters, take the patient in the first 10 days and revise your surgery, because they tend not to improve after that, and it is very easy to remanipulate the tissue in the first 10 days before the fibrocoagulum will be completed and fibroblasts will lay down the healing process. If the levator function is poor, you can go for for frontalis suspension. And you can see here the main principle here is to attach the tarsus to the frontalis muscle. And patient here, when he's using the eyebrow, it will accentuate the ball of the eyelid. As you can see here, using frontalis, think different techniques, the pentagonal, the Crawford, or whatsoever, different materials also proposed, but always remember in frontalis ring, the position of the eyelid will be excellent on the primary gaze. But if the patient is looking down or closing the eye, lag of thalmus will be evident. Regarding the aponeurotic type of ptosis and involutional is a subcategory, the eyelid crease is higher or absent, depends upon the degree of ptosis that you will see. The levator function is good or excellent. And in elderly patients, you'll find thin eyelid tissue because one of the layer is recessed upward. And you will find here the other way around. The eyelid is drooping more on down gaze. As you can see here, the eyelid crease here is higher, and the eyelid here, which is dropped, is lower than the other one. This is unlike the congenital type, and you can see the superior sulcus syndrome here and the very thin eyelid. It might be involutional, it might be aponeurotic acquired. Usually you see it in patient who is continuously rubbing his eye due to allergic condition, vernal keratotic conjunctivitis. As you can see here, the lid crease is higher, and when the patient is looking down, you can appreciate the lid crease more here, and this eyelid is lower than the other one. The aponeurotic ptosis will be lucky if you see this patient because the treatment is very simple, straightforward, and local anesthesia. Just take 1, 2 sutures, and you can detect the degree of improvement on the spot. If the patient has both involutional and congenital elements, it is a good and wise decision to take it in 2 steps, to correct the involutional element and evaluate the aponeurotic element and evaluate the patients later on to decide how much do you resect, especially if you do it under general anesthesia. But under local anesthesia, you might do both at the same time, but always avoid resection in such cases. Those patients tend to have overcorrection post-operatively, even if they are intraoperatively the eyelid in a good position. The levator resection here should be avoided in aponeurotic type. And if you do it, always remember to do advancement or leave a fringe from the levator that you can take back your procedure. If the patient having neglected congenital ptosis, always remember when you discuss with the patient, they tend to have very small exposed ocular surface for years. So post-operatively, if you correct the patient to the normal position, they tend not to be happy despite having good aesthetic outcome. My eyes is not, I wish if I had it back. So always you have to discuss this with the patient with neglected congenital ptosis and go more towards undercorrection. So the take-home message, first, whenever you see a patient with congenital ptosis or acquired ptosis, you have to exclude pseudoptosis. And always remember to exclude dangerous ptosis and to work patients up if you have such a case. You have to inspect the patient and always remember, do not miss the forest for the trees or whom are behind the scene, like myasthenia gravis or jaw winking Marcus gun phenomena. Never ever miss amblyopia in pediatric age group, and you have to discuss the outcome with the parents or patients, and then you can open the eye safely for life. The complication that happens post-operatively in case of ptosis, it is very important to discuss it with the patient in terms of side effects and the complications, the need for another surgery. The patients tend to accept these side effects or complications if you point it out before surgery. If it happens without mentioning that, patients will be really agitated, especially patients for ptosis, they have very high expectation. Thank you. Do you have any question? Yes, Tariq. Welcome. Getting topic, yeah. Yeah, definitely. The first, the discussion with the patient. So if he is happy with the current position of the contralateral lid retraction, I would say that. So tell the patient that we're going to overcorrect this eye, and we have two options. Either to do bilateral surgery at the same time to correct the possible eyelid drooping post-operatively, or we'll make it in sequences. So we'll do this eye, and post-operatively you will be in need to go for surgery on the other eye. If he is, after you elevate the ptotic eyelid, he is satisfied with the new position of the other eye, so go for undercorrection of that eye and tell them that mostly will go one side only, but be careful post-operatively, you will be having both eyes are slightly downward position if you are looking for wider palpebral fissure. Male or female, I think it might be a major issue here and of concern, because females tend to have wider palpebral fissure. So in females, usually to go bilateral, or tell them that we'll do this eye and later on we'll go for the other eye. I don't know, Prof. Diego, if he has a different view, different opinion. Okay, thank you.
Just I would put this is the venue. I think absolutely I agree. I agree with you that for ptosis less than 4 millimeters we have actually we go for frontalis doing the silicone. But I have tried also some people recommend also as a
thank you to bring this up, Prof. Diego. Actually, I did not go deep on this, but nowadays I tend to do levator resection rather than frontal sling, and I release the retinal ligament. In congenital ptosis with poor levator function, they tend to have some abnormalities not only on the muscle, in the aponeurosis itself. It is usually rarified, thin, multiple adhesions here and there. So the post-operative lid lag and lag of thymus is way better with levator resection than with frontalis, especially if you are going to operate one side only. Bilateral, if they tend to have bilateral, I'm more towards frontalis sling because the outcome, the patient's aesthetic outcome is better. But in unilateral, I tend to go for levator resection, maximum levator resection with retinal ligament release. It gives really good result. And still, you have it in your armamentarium. If it does not work, you'll go for frontalis sling. Okay. No more question? Yes. Always remember in frontalis sling, what we are doing here, we are maximizing the pulling effect of the frontalis muscle on the eyelid. Actually, it is transmitted through the skin when you are elevating your eyebrow. So we are putting materials to make a direct pillar between the frontalis sling and the tarsus. We have opposing function here, which is the orbicularis. So the orbicularis is squeezing, pulling your pillar downward. So if you don't fix your pillar in a good way to the tarsus, and this is a case that we usually do, we do it up external in a closed technique. And this is a material which is inert mostly, so the patient, the tissue will not make much more fibrosis over it. So it tends to cut through. To cut through from above, to cut through from down, it depends. But usually we see it cutting through from down. If you use fascia lata, now the fascia lata is really forming a good fibrosis, a very dense fibrosis over it. So seldom we see undercorrection if we use fascia lata post-operatively. And this is why, if you think about to revise your surgery, for example, if the patient has ocular myopathies, and you might have exposure and you might go to revise your surgery lower down, don't use fascia lata. Fascia lata result there is there, and it's usually stable, okay? To do it, a lid crease incision or closed technique, this is the issue now. If you have frequent undercorrection, it is better to do it up lid crease incision and fix your synthetic material with non-absorbable suture in the tarsus. It causes some foreign body reaction, etc. It has pros and cons, but it tends to be more stable. The advantage of using Dyna rod, after you fix your surgery, if they tend to have undercorrection which is not marked, so when you put your finger here, you can see the rod, it is not markedly going up. You can just under local anesthesia open here over the sleeve and readjust it post-operatively. But the synthetic material, it tends to have undercorrection because of the cutting through, slipping, unlike the fascia lata. Okay. So, okay. Thank you so much.
first with this very nice, okay? Yes.
I have previously. Now I'm comparing how I look now. I have one 3 years ago, or 4 years ago.
Oh, really? You got it?
Yes, I got one with you.
Where did we take
Kuwait.
it? No, but where?
In the
Al-Bahar?
Raya. In the Raya.
Ah, right, okay.
When
Yeah.
you give a presentation.
Yes. For Barcelona.
Was the bimanual vehicle.
Yeah, Barcelona.
Exactly.
Exactly. Very
Just
good.
like this.
Send it to me. You have my phone number, right?
That's it.
It's 0034 670 33 33 44.
Thank you.
Okay. Thank you. I will give you my email. Email is practical terms. It's JL
Like that? Thank you.
How was it?
Hi, fine, very good.
Do you need water, anything?
I need time. I need time.
Anytime?
No, no, nothing. Nothing, but I have your bar. But you know, very, very interesting meeting in the ministry. And I think that we have things to do. Okay, so we will
Assalamu alaikum. Good afternoon, ladies and gentlemen. It's our pleasure to welcome Professor Jorge Alio. Professor Jorge Alio is visiting us for the third time here in KKESH. He's the chairman of the Vision Eye Center, and he's a professor in the Fernandez University. He's well known to us as one of the leaders in the field of cataract surgery. He's delivering a lot of presentations, more than thousands, but the interesting that he have a time, as you grasped today in early morning, to publish more than 80 books and 800 articles in beer and non-beer review journals. His work is always interesting, especially in the field of the cornea, and one of his interests is in the stem cell regeneration. So he's going to share with us his experience as he's among the first to start the corneal stromal regeneration projects in the world. And it's of great interest for us because it will address one of the most common disease that we encounter here in Saudi, which is keratoconus. So I would like to welcome Dr. Elio, and we'll ask him to start the presentation. Looking forward.
Thank you so much for this very nice and friendly presentation and introduction of me. Dr. Abdulaziz Al-Raji, thank you for this opportunity to visit this distinguished center and for all of you to take your time in this middle time of the day to come for something that I have put a lot of interest, me and my team, because we do believe that we are at the beginning of something that is going to change the future of our practice, the future of our surgery. I'm sure that the next 20 years, the future of our practice will be regeneration, tissue regeneration at different levels, including the retina, but not starting from the cornea. I work in Alicante, Spain. It's the southeast part of Spain. We have a place which is similar to Florida. We are welcome. We're blessed by God for many things. One is the weather. We receive about 7 million visitors per year in our place, and that means that we have a very international practice. This is the center that I created in Alicante. I am chairman of the university, and I have to thank my team. My team is, first of all, a Lebanese group that made possible this study, and this study was made because they funded the study. Now the government of Spain and the European Union, because they funded the continuation of this study in the Spain in a multicentrical trial that is starting right now. Right now means probably next month. And Óptica General, which was the one that sponsored the study in Lebanon, is acknowledged here because they made these results possible, coming from 10 years of basic research to translational application in the human being, which are the results we are going to show to you. So we're not going to talk about rabbit experiments. We're not going to talk about experimental animal models. We're going to talk about phase 3 clinical trial with real results after 1 year of corneal regeneration. So first of all, we have the challenge of keratoconus. Keratoconus is classified in Europe as a rare disease. In Spain, it's not a rare disease. It happens to be probably 1 in every 500 to 700 inhabitants. European Union says that it's 1 in 2,000, but it's not in our, probably it's the background of our ethnicity and the climate, what makes this combination of factors to be keratoconus frequent. It's very frequent here, I know. You don't have a statistic, but probably it's 1 in 200 cases in this lovely country where you have. The problem is that we have different therapies, and different therapies that are invasive, substitution the tissue by a corneal graft, but is it possible to treat keratoconus in a different way, creating the regulation of the corneal stroma with a minimal invasive procedure? That this question was the one that we raised 10 years ago, starting with animal models that I'm going to just to mention, but I will not go through, leading finally to something that is real, which is the possibility to treat keratoconus without any foreign tissue, without any foreign material. So the tissue engineering, as you know, is a very important topic. It's a topic of today. It's the way in which we are combining cells with materials and environmental factors that involves cytokines and other type of products that are in release and signaling the tissue in which we put the cells in a way that they recreate new type of tissue that is the same tissue in which they are implanted. This signaling and this cell biology methods are creating a new brand of medicine that is going to be in our generation, but especially in your generation, much more important and will substitute gradually surgical procedures that we do today. And the issue is that we try to find an alternative for classical corneal transplantation to regenerate the corneal stroma. The preclinical study was performed by some of my collaborators, but I want to mention Dr. Arnalis, who was the first. He did his PhD graduation on this topic, and then my son Jorge is my elderly son, who did also the study, and we published the first paper in 2010, 10 years ago. In these papers, we demonstrated that using human cells in the rabbit cornea, with femtosecond pockets leads to the production of human collagen in the rabbit cornea, which was really something that demonstrated with no doubt that our cells, human, were producing independently from the environment collagen that was detected and demonstrated in these 2 studies. Then we went through the finding of scaffolds, and these scaffolds were different. We tried synthetic scaffolds, different type of organic scaffolds. Finally, we found the scaffold. The scaffold is the human collagen cornea without cells. I will go through this. And we started the clinical trial knowing that we had cells that were capable to produce collagen in the environment in which they are placed, the cornea, but were from the same chemical origin. I'm talking about adipose cells from the same individual in which they were transplanted. And we knew that we had a carrier, which was the decellularized acellular corneal laminas of 110 microns, capable to carry these cells and successfully increase the thickness of the cornea, as we saw in the experimental animal model. So we tried to make a phase 1 human clinical trial, and this phase 1 human clinical trial was registered in clinicaltrials.gov, was approved by the Lebanese University. The reason why we did it in Lebanon, because it was almost impossible to find the permissions in the European Union, in Spain especially, to make this study translational. That means to go from the rabbit to the human being. And in Lebanon, we cleared all the ethical issues. We cleared the financial issues because the company, Óptica General, sponsored everything. And then we went to a study that was without any precedent. So no precedent about the use of stem cells in the cornea of autologous origin was never tried. So we had exclusion criteria, keratoconus, that were of compasive indication for this therapy. They were indicated for corneal graft. They were using contact lenses, really contact lenses, and we had a compasive indication based on these patients with need corneal graft. And finally, we excluded all comorbidities that could affect the organ, especially those of the ocular surface, and we alerted the patients about rubbing, allergies. All these problems were apart, and we selected cases of volunteers that on purpose they entered the study. And then we used the stem cells from their own patients. These stem cells came from liposuction. Taken from liposuction, we identified the stem cells, we expanded the stem cells, and about 3 to 5 days after the extraction, then the stem cells were used for the purpose of corneal regeneration. These are the cultures of the stem cells that are autologous stem cells of mesenchymal origin. That means they are multipotential stem cells, mesenchymal stem cells. This was the issue, and this is the way in which we use the cells. If you see the movie, we are with a 9.5 millimeter femtosecond pocket. This pocket was created and the pressure was lower with a parasite tissue in order to harbor 3 million cells in 1 cc that was injected. Look here how is the way in which we injected the cells, and this injection of cells made the pocket to be filled with them. Obviously some of them could get out, but 3 million cells were injected. We did 1 stitch and the patient, and this was all the surgery real time. So this is what is the time that lasts this surgery, and we follow up the patients up to 12 months, and we have a lot of exams that were performed systematically by the same person, by the same technician, analyzed by the same monitor, and this monitoring process was also the one that followed confocal microscopy. So we had 3 groups, one only with cells, and then 2 more groups, one in which we took corneal laminas 110 microns thick. We created a process to decellularize to make all the cells out from the tissue, and so we had only collagen fibers of the cornea there with no cells. And this was group 2, and in group 3 we took these same laminas, and these laminas were repopulated with stem cells from the person. So we had group 1 only cells, group 2 only laminas, group 3 laminas plus cells colonized and incubated for the purpose. And then these in these 2 groups we use a femtosecond pocket. The cells, the laminas were implanted. The study was consecutive, non-randomized, so the patients were consecutively operated, and the post-operative treatment that we follow was the normal one that we use for cataract. And the fundamentals of this were based on this basic study. So this was the experimental animal model in which we had the evidence that we could repopulate these laminas with the cells in a way that was keeping the structure transparent. The issue was very surprising, because if you follow the literature, you know that the use of lenticles from smile, these lenticles become opaque and with haze, most of them. We never had haze, you would see it, we never had problems, and the issue is that the signaling factors in the stroma were there, accepting the cells and making the true problem. So this is not a transplantation. This is